Thank you, Dr. Puri. That was such a wonderful overview of the biliary strictures in liver transplant patients. I have a few questions, but I just want to ask, how many of my audience actually are doing ERCPs? I'm sure I see a few of them very well. I know them, Dr. Kuru, Dr. Jargar. Please feel free to ask any question. Raise your hands, and I'll ask. And those who are not asking questions, also, I'd like to please make sure that you mute yourself, so that way we don't get any disturbance here. So, Dr. Puri, rejections in acute rejection and chronic rejection, you mentioned there is strictures. These are inflammatory strictures. What's your experience about that? How do you just wait and watch and let the rejections being treated and not to intervene in those situations? What do you do?
So I think thank you, Dr. Satpathy, and let it be honest, as we are not hepatologists, our hepatologists try to treat. When the patient comes with the rejection, they try to treat. We only comes with the symptomatic strictures. They refer the case for that this patient require biliary intervention. We generally don't see the post-transplant patient. Patient comes to endoscopy for the treatment once they are sure that, yes, this patient require ERCP intervention.
That's great. Thank you so much. And please, audience, those who want to ask any questions, please raise your hand so that I can prize you while I'm asking some questions. Yeah, Dr. Kuru, please. Yes, please, Dr. Kuru. You're very welcome.
Rajesh has given an excellent overview of and his personal experience on biliary strictures and leaks and bile cast syndrome following LDLD. Now, I have an experience of more than 400 patients, but not here, while at King Faisal, and most of the transplants were cadaveric. But in later part, we also dealt with the live donor. But more important is there was a small group of very interesting donors, what we called as CD, that is the cadaveric donation after circulated death. Now, these patients were done from China. There's a significant group of patients who transplant were done after the circulated death. And I don't know, Rajesh might like to make a comment, but now this type of donation is really started coming up in the West also. But this is a very interesting group of patients where you have a donor from a circulated death. We've seen several patients of that. And but for the cadaveric transplant, our biliary strictures were 20%, and majority of them were leak. There were strictures of hepatic artery thrombosis and strictures anastomotic, then bile cast. There were some patients of recurrence of earlier biliary disease, like sclerosing cholangitis and also sphincter body manometry, abnormalities. There were several patients who had a problem of the sphincter, and biliary manometry showed that. So I don't know. This is another interesting thing that you do transplants from donors who are circulated. Does anybody have experience? Because I have quite a bit of experience on that.
So I have no experience, sir.
Yeah, so we actually I have a new transplant center where I'm working. Last 4 years we started. We haven't been doing a lot of DCDs yet, but in my previous transplant center where I was there for 11 years, I used to be the sole ERCP person for the program itself, and with another partner of mine, both of us were doing. But we had about 25% of our patients were DCD liver, or donation after cardiac death, and these patients are more likely to develop both anastomotic as well as non-anastomotic biliary strictures, and this is quite common. It's sometimes very challenging. These are patients who develop ischemia reperfusion injury, and they're more likely to prone to develop these strictures, and variety of strictures. Yes, sometimes difficult to treat.
The experience I had with was these patients were done from China, and there's a large group of patients, and majority of them had mutilating biliary disease, because the time between the circulated death, which was done probably in a jail by a blood and giving the liver was 1 hour, which was too delayed, and we had to really stop getting our transplants done from that country at that time. But now that this is a common way of looking at donor supplies, and the type of biliary strictures are much more in this group of patients than either in cadaveric or in LDLD. We compared that. We had actually 400 patients. We have published, is a good publication on that. We compared the LDLD and the cadaveric transplant, and also mentioned only about this circulated death. LDLD issues are what Dr. Rajesh put brilliantly, much more difficult than in cadaveric transplant.
Agree, sir. I also have a couple of other questions, Dr. Puri. The metal stents, when you cover metal stents when you use it, these post-transplant patients have longer length of the bile ducts in a vast majority of these cases. And when you have this longer length, the stent that is available is up to 10 centimeter long at max. That's, as far as I know, unless it's different in India, it's available. The Boston Scientific has a 10 centimeter, and then we have the viable stent, which is also a max of 10 centimeter. Of course, the diameter also varies from 6 to 10 millimeter. So how do you choose, number one, the size, especially when you're applying in a structure cases? And second, when it doesn't reach up to this size, like the structure is like more than 10 centimeter, how do you plan to deploy a metal stent, or you do not apply it at all a metal stent? So that would be my question.
So thank you, Dr. Satpathy, for an excellent question. So during my lecture, I discussed we use a dedicated coffee stent, which is 3 centimeter in long. We don't use the Boston or other stent, which is fully covered, used for the benign biliary strictures, which was 6 centimeter or 8 centimeter. 10, I don't think they are available. They may be available in the US. But these coffee stent has a long lasso, which is hanging into the duodenum. So what you require, you put the stent, and the stent lasso deployed into the duodenum. After 3 months, you just pull the lasso, and the stent will come out. So 3 centimeter long stent, which remain intrahepatic with the long lasso outside, and you just pull it. I have shown in my diagram also. We don't do, you might be putting the fully covered, which is 6 centimeter, 8 centimeter, because you come across with the DDLT strictures. And they have a longer than in those cases, but the coffee stent, which is 3 centimeter, will be very useful even if you put in the DDLT patients.
I see. And what is the lasso? You mean there is a wire or something that's kind of hanging
There's a
out?
wire.
I
Yes.
see. That's
In
very
my
interesting.
I have a video also. It was not running here. It was at that time. The lasso was hanging. It was shown in one of the fluoro image also. That lasso hanging inside the duodenum from the bile duct. And you just pull it, the lasso, and the stent will come out from the intrahepatic ducts.
That's very interesting. And I think I learned something on that. And all right, so I have one.
Rajesh,
Yes,
Dr.
Dr.
Rajesh,
Jargar. Please go ahead, Dr. Jargar.
yes, I think really an excellent review on the subject. I would like to just ask you a few things. That what was the success rate of those strictures which failed repeated endoscopic intervention with the surgeons? How often they could succeed, have anastomosis? Second thing, what is your long-term follow-up of these strictures?
Yes, sir. So what we have presented in the ILTS is 3 years data, and that shows a 90% resolution. I've shown the ILTS data, which I summarize. I will again tell you the data which we have presented in the ILTS. That is total 1,536 patients. 53 patients has a multiple duct anastomosis. And when these patients are followed up for 36 months, from 1 month to 93 months, they have a 5-year survival of more than 90%. And those patients which you are talking, which has resistant strictures, these patients may require 7 to 8 ERCPs also sometime. But that is a very small subset of these patients. These patients keep on coming for the ERCP, sometimes 7 times, 8 times, but average around 3 sessions are required. You dilate with the biliary balloon and you put the stent. And this also seen, these patients has a recurrence of the strictures also. They may come back after 1 year or so with the cholangitis and you treat them. But we have now, actually this data, as I said, it was presented in the ILTS by our hepatology team. And the latest data, I will ask them to show me. And if given a chance, I'm going to tell you the data till last year, what is the recent data which we have. But I have presented the data till 2019.
Thank
What
you.
was the success rate with the surgeons? You didn't, I think that question. The
So
patients
six patient require surgery, repeat HJ.
and was this successful surgery, or they land up again in retransplant?
So what the data which I have, according to them, the retransplant was not done. But Dr. Jargar, like I can inform you again by discussing with them. My best of knowledge, none of the patient has, generally they don't do the retransplant for these patients. But I can ask our surgical colleague and I can let you know. It may be very rare. Retransplant are not commonly done because all patients underwent ERCP through us. We very rarely come across that the structure is not remodeled. So these patients should not have gone for the repeat retransplant for the anastomotic, non-anastomotic stricture. As I said, 6 patients require an HJ in these cases, which I've shown in that. 6 cases salvage hepaticojejunostomy. I've shown the data. 89% managed with the ERCP alone, 11% require combined PTBD, ERCP, and 6 cases require a salvage hepaticogastrostomy.
Thank you. Does that answer your question, Dr. Jargar?
Okay. Yeah.
Thank you.
Thank
I
I will ask my surgical colleague, any retransplant was done for the biliary stricture, which I'm going to message Dr. Jargar.
So, Dr. Puri, one of the questions, like above the stricture and anastomotic stricture, sometimes you have these stones, right? And you mentioned some of these cases you have to go to cholangioscopy and you can actually break it down. My question is, sometimes these stones are very mushy, meaning you cannot really break it down. And you use a balloon, you try to pull it out, they just stick around that wall. And in that situation, we're not able to clear it out. You just put a stent back and until, because I have a patient which I'm doing it serially at least 2 times. I haven't been able to get it out. And I put a metal stent just hoping that it's going to all fall through it, but it's still having those, the mushy stones or filling defects keep coming every time. And I'm not able to get out without a stent.
That is a typical case of bile duct cast syndrome.
Yes, yes.
It's a typical case of bile duct cast syndrome. And these patients require retransplant. And I distinctly remember one of my patient has this problem. I told you during my talk.
Yeah.
He was managed for 6 years, 7 years. And fortunately, he was lucky to have a stent free and he was not developing cholangitis. Later, I think he re-underwent the retransplant. I think I'm not very sure. I don't have follow-up. But one case I distinctly remember, biliary cast syndrome, what you are talking about, mushy kind of blackish material, you are not able to clarify. So that is a biliary cast syndrome, and that is a very high rate of endoscopic failure. These patients require a retransplant.
Thank you.
Dr. Sanjay, I remember seeing 3 or 4 patients in these 400 transplants of biliary cast. And because we were dealing with a cadaveric transplant, I think it's a pleasure to retransplant these patients. While at Medenta, live donor, I think it would be a big problem to do a liver transplant. You already have had, somebody has given a liver, one of his brothers or sisters, and then spend so much money, and then asking for another transplant is asking for trouble. But in King Faisal, this was not a problem because we were using cadaveric transplant, majority of them, and anytime the liver is available in such situations where there's a biliary cast or difficult disease in the biliary system, like hepatic artery thrombosis, where the strictures are so multiple, intrahepatic. I think retransplant is an indication.
So, sir, that patient has had a liver transplant from Singapore, I think, or from Korea, because he was not, and he was coming again and again, and we advised him to go, and he wanted to go back there. So for 5-6 years, I distinctly remember we followed him up. But after that, what happened to him? Has he gone back and retransplant or so? I can inquire from my transplant team.
Sanjay, can I think now that you are really on the transplant and you're coming to India very often, what about talking about the CDCD, that is a circulated death, because it's difficult in India to really have the whole system of cadaveric transplant, because the system needs to be so meticulous. But in the circulated death, transplant should not be a problem. So maybe you can propose to the centers that they can increase the number. At least in UK, I think the number of circulated death transplant, donors is about 25% now. I don't know what about US. What is the number?
Well, this is going to pick up, and the reason for that is this, the warm reperfusion. Like now the new machines have arrived, where you can actually keep this liver for a certain duration of the time, and without causing much of a ischemia reperfusion injury. So normothermic perfusion has come in a big way, and we do have a machine at our center now. So many of the centers have started using it. So I think we'll start seeing more and more, but with a less complication though. So that's a good thing about it, because the normothermic perfusion wasn't there widely used in the past. So now that's coming up. So the preservation techniques have improved. So there will be less strictures, I believe, but certainly those kind of donors will pick up.
Thank you.
Dr. Dokumissi, how are you?
Hi, thank you very much. It was excellent talk, and also discussions are very, very valuable. I have one question. Actually, sometimes in few cases, we cannot cannulate the bile ducts, and we use the endoscopic ultrasound. How about the speakers? Is here any kind of this kind of experience about the endoscopic ultrasound to cannulate the bile ducts?
So thank you, sir, for asking this question. So I'm a therapeutic endo ultrasound person who do a lot of biliary drainage, but in my entire career, I'm doing ERCP for the liver transplant for more than 18 years, because the liver transplant started in my center when I was in Gangaram 2001. And after 4 or 5 years, we start getting the cases. So I never used, and it never happens that there is a ERCP failure of cannulation.
Recently, in those cases, we use, especially in cadaveric liver transplantation, we use the magnet, as you mentioned, and also we use recently endoscopic ultrasound. Then we fail to cannulate percutaneous way or endoscopic ERCP way.
So in DDLT, definitely you can do it. And actually, I will tell you a few things. Like we have around 8 or 9 cases where we have created a new tract. New tract means hepaticogastrostomy, or we have created a hepaticoduodenostomy by the IR people. And IR people are blind. We can do with the help of endoscopic ultrasound. Actually, this will all depend upon the performer, and the unit should have a faith in you. As I have demonstrated 3 cases where the hepaticogastrostomy and hepaticoduodenostomy was done by the IR people. And they are blind. They puncture through the transgastric route and they convert that, putting the wire, more risk of the biliary leakage in those cases also. So I think it is a confidence of the parent unit, confidence of the endoscopist. But generally, when we do ERCP, 99% of the time you don't fail in ERCP, that there is no cannulation.
Dr. Puri, just to piggyback on that, sometimes you have difficult ERCP. I mean, we never fail, but sometimes you have difficult ERCPs and for cannulation. What's your experience of doing pre-caught in situations like that? Do you pre-caught use quite random, quite often in this condition, like post-transplant patients?
Yeah, around 20 to 25% of the cases. And frankly speaking, I
An endoscopic testing, you may need an endoscopic ultrasound.
Yes, I absolutely agree, sir. I don't have an experience with this, in spite of a good endosonologist practicing, but we do with the need of intervention radiologists to do that work. We don't use EUS, but definitely this can be used.
Thank you. I think this is very interesting discussion, very high level as well, and very interactive. Thank you again, everyone. Dr. Puri, thank you.
Thank you very much.
Good night.
Bye-bye.
Bye-bye.
Thank you, Dr. Puri.
Bye-bye.
Okay.